everyone, my name is Dr. Sameera Irfan and this is the second lecture in the series of conjunctival diseases. I suggest that you should listen to the first one initially so as to know what are the normal structures of conjunctiva and how is the correct interpretation of all the clinical signs like papillae, follicles, how they are formed and conjunctival edema. And then you go on to this lecture. So, diagnosing conjunctivitis, the objectives are that you should be able to diagnose conjunctivitis, its different causes, and you should be able to differentiate the other causes of red eyes. Then, after listening to this lecture, you should be able to identify the exact cause and so as to prescribe the correct therapy. You should be able to prevent complications not only from the disease but also from the therapy that you are going to prescribe to your patients. Some of the conjunctivitis like allergic, they keep on recurring annually, and the patient, especially children, have to be on therapy for a long time. So your therapy should be safe, it should not cause any problems to the children or to anyone's eyes. And last of all, the diagnosis, the accurate diagnosis is important to prevent the spread of infectious diseases by educating your patients all about the disease so they can prevent it, and not only the patient but also the attendants. They should know what the basic cause is and how to prevent from transmitting to other people. So, important to know the exact structure of the ocular surface. The concept was given to us by Toft, and it comprises of 6 structures: the cornea, the conjunctiva that covers the sclera, and then the tear film, the precorneal tear film, the eyelids, the adnexa, and the lacrimal drainage apparatus. All these 6 structures, they work harmoniously because they have a common nerve supply, blood supply, and hormonal control. So if there is a disease of one structure that comprises the ocular surface, that disease process spreads to the other structures too. For example, a simple conjunctivitis can affect the cornea. It can later on affect the precorneal tear film and can cause dryness, and continued dryness can cause the punctal occlusion as well. So all systems, all the structures will be eventually affected. So when the patient comes to you with a long-standing conjunctivitis, you should be able to diagnose whether it has affected the tear film, whether it has affected the cornea, and how you are going to manage it. So the tear film is a blessing for us. It not only cleanses the eye, it wets the ocular surface, it washes away any bugs that may find entry to the eye. Our eyes, with the lids open, they are exposed to the atmosphere all the time, and any kind of allergens, dust, pollens, and all kinds of bugs can find their way on the ocular surface. But if the tear film is healthy, it can wash them off and a person is prevented from having the disease. In addition, the tear film, it provides us with immunoglobulins, enzymes, complement, and mucins. The free mucins in the tear film, they engulf every bug or the foreign matter that lands on the ocular surface, and then the tear film, it washes it off and a person is prevented from having disease. So if the tear film is interrupted or interfered with by either your therapy or the disease, then a person will not get better with your treatment. So when a patient comes with a red eye, you have to decide whether it is a bacterial conjunctivitis, a viral, chlamydia, or is it allergic. So the treatment of all these conditions is different, or it's only the red eye is due to a dry eye, due to a tear film instability. So what is conjunctivitis? It is defined as an inflammation of the conjunctiva which is characterized by vascular dilatation, cell infiltration and exudation. And it could be acute, it could be chronic and recurrent, or it could be associated with systemic disease. Acute would be if it presents only for a few days and is self-limiting. Chronic is if it has been going on for weeks or months, and recurrent that the episodes appear during a particular season and then they clear up, and then during the year it comes up again, or every year the patient has a problem. So that is recurrent. And then it could be associated with systemic diseases like asthma, like atopy, gonorrhea and plasminogen deficiency, especially causing ligneous conjunctivitis, which is extremely difficult to treat. So if you know the structure of the conjunctiva, it is basically composed of epithelium, and then in the stroma there are numerous vessels. So as soon as the allergen or the bug, it lands on the conjunctival surface, there are the mast cells in the stroma, and those mast cells, they degranulate with the release of histamine, and that histamine then causes acute vascular dilatation and congestion. Then from those dilated blood vessels, there is leakage of plasma or serum, and this causes a watery eye because it causes a lot of irritation, and there is reflex tearing. In addition, the oozing of serum from the blood vessels, it causes edema of the conjunctiva, and there is a lot of congestion in the eye. Along with the serum, there is movement of cells from the blood vessels, and these cells, depending upon whether it is virus, so there will be lymphocytes. If it's a bacteria, there will be polymorphonuclear leukocytes. Those polys will fight with the bacteria, and there will be formation of pus by the fight between the two. And if you see pus, then you will know that yes, this is bacterial conjunctivitis. But if it's only water coming out from the eye, then it's most likely viral conjunctivitis or allergy. Then the deeper tissue of the conjunctiva undergoes edema as well as discoloration of superficial epithelial cells, and you will see debris in the tear film. So the pathogenesis is, number one is the vascular response, which is by the histamine, and there is dilatation and leakage of serum as well as cells depending upon the bug, what it is. And then there is the conjunctival tissue response, and then that conjunctival discharge, which could be watery, pus, mucus or bloody. And looking at the discharge, you will be able to diagnose what is the exact cause. So if there are allergens, a person has an allergic conjunctivitis, then in the conjunctival stroma there are memory cells. And those memory cells, they retain the memory that the person was one time as a child exposed to that particular allergen, and that memory stays in those cells. And those memory cells will react and they will be triggered as soon as that patient is exposed to that allergen. And those the triggered memory cells will then cause mast cell degranulation, histamine release and the whole cascade, and there will be capillary and tissue response. On the other hand, bacteria, they will cause the inflammation by activating the complement and result in acute inflammation with again the signs of dilatation, congestion, leakage of serum as well as white blood cells, and then there will be dead polys, epithelial cells, bacteria and RBCs in the discharge. Depending upon how aggressive that bacterial infection is and how much load of the bacteria there is, the vascular congestion will depend on that, and if the vessels are too much dilated, the infection is too severe, then there will be leakage of RBCs and there will be bleeding spots seen on the conjunctiva and subconjunctival hemorrhages. Viruses, on the other hand, they only cause epithelial cell invasion, proliferation, cell lysis of the involved epithelial cells to form virions. Viruses, they are parasites. They cannot directly infect an epithelial cell, a healthy epithelial cell. And viruses, because they are parasites, they need a host. They cannot proliferate on their own, multiply on their own. So they land on a healthy epithelial cells, invade the cell, and then multiply in it, and once the capacity of the cell has finished, then that cell will rupture and the tiny virions are released, which again cause acute inflammation and exudation of plasma fibrin virions that will infect the remaining epithelial cells, and the process will continue. So conjunctivitis simply starts as an acute process, and then the inflammation can either stay limited to the epithelium, or it can affect all the structure, the stroma, as well as a lamina propria of the epithelium, of the conjunctiva, depending upon how severe the inflammation is, how severe the infection is, what is the load of the bug or the antigens. And there is involvement of all layers of the conjunctiva. The absence of healthy mucin is a main complication of conjunctivitis, because mucin is produced by goblet cells which are present in the conjunctiva. So if those goblet cells are diseased by the inflammation, then they will not produce healthy mucin. And if there is no healthy mucin, then the tear film instability occurs. So the dry eyes, they are a part and parcel of any long-standing conjunctivitis. So dry eyes will not only occur because of the conjunctivitis itself, because the goblet cells are affected, but also because of the usage of eye drops which have preservatives in them, which may have decongestants, and they directly affect the tear film stability and dry eyes, chronic dry eyes. Then chronic inflammation may occur due to chemical toxicity of the eye drops as well, along with the topical steroids, which are very rampantly given to such patients, and they cause additional collateral damage to that eye, like glaucoma, like cataract, and predisposition to other viral infections. So proper diagnosis, proper management is extremely important. That we will cover in the next few lectures. First will be on viruses, then on bacterial conjunctivitis and immune-related conjunctivitis. So any red eye, you have to differentiate whether it is viral, or it is bacterial, or is it allergic, or is it a toxic conjunctivitis. Toxic mostly due to chemicals and drugs. They're topical drugs that we give to our patients for any other problem. Allergic could be seasonal allergic or perennial, and viral could be adenoviral, herpes simplex or zoster. Acute bacterial could be due to any non-virulent bacteria as well as virulent bacteria. So as I said, for every disease there are predisposing factors. If there are 100 people in a community, not all of them will get that disease. So talking about conjunctivitis, they all will not get conjunctivitis. Why? A patient who develops the disease has some predisposing factors. So for allergic seasonal conjunctivitis, there is environmental pollen to which that particular person has memory cells and is allergic to that. For vernal conjunctivitis, it's those children who live in hot, dry climates. As soon as the winter season starts, the conjunctivitis gets better and better controlled. But as soon as the summer or the spring starts and there's a lot of pollen, and dust and humidity, the flare-ups occur. So these children have to be protected. It's better that they stay in cold places, or they don't play outdoors during the hot weather. Then for atopic conjunctivitis, there is always a genetic predisposition. The atopy runs in families. And then there is environmental influence of pollen, of dust, house mites, bed mites. They all lead to the increased prevalence of atopic conjunctivitis, which is very difficult to treat. And it has all these allergens. They have to be avoided from the life of that patient. Giant papillary conjunctivitis, the predisposing factors are chronic wearing of contact lenses. Then following any sutures, following surgery in a patient, any sutures that are left in the eye and their knots or their ends, they are irritating the eye, they have to be removed. Ocular prosthesis in people who have lost their eye and they are wearing a prosthesis. The prosthesis is a heavy material and the eyelid, it rubs against it, and so it can cause giant papillary conjunctivitis. Toxicity due to preservatives, contact lens solutions, pediculosis is a cause in toxic conjunctivitis. And adenoviral, usually there is an exposure to an infected person. Molluscum contagiosum is seen in immunocompromised. In that immunocompromised person may be due to diabetes, very common, and due to taking any steroids or any other immunosuppressive drugs. For bacterial conjunctivitis, it's important to find out where are those bacterial load coming and why are they infecting that eye. So in a neonate, usually the onset of neonatal bacterial conjunctivitis is from the birth canal of the mother is usually infected. And the timing or the onset of conjunctivitis tells us where the problem is. In an infant, a chronic congenital nasolacrimal duct obstruction with pus pouring out from the lacrimal sac that can result in a chronic conjunctivitis, bacterial conjunctivitis. Then infants with chronic pharyngitis, otitis media, they generally have a poor health, and the bacterial load, it can affect the eyes. In adults, contact with infected individual, oculogenital spread, infection of adnexa. Most common cause is a blepharitis. Many people, they have blepharitis and it is not looked into, and it can result in chronic conjunctivitis. Mabumin gland dysfunction is very common cause of secondary bacterial conjunctivitis in adults. It's a very common problem. Then smoking, trauma, immunosuppression, occupation, people who are working indoors whole day, they tend to develop dry eyes, chronic dry eyes, and any bug that is in the atmosphere, in the absence of tear film, those bugs, they will infect the eye and will cause bacterial conjunctivitis. And smoking, it reduces the tear film stability, it irritates the eye and leads to chronically red eyes. So it's easy to diagnose the main cause and the predisposing factors if you have taken a proper history, and that history would be regarding the symptoms, their onset, whether they appeared suddenly, and their duration, exacerbating factors, whether it is unilateral or bilateral. Most allergic conjunctivitis, they are bilateral. Then viral, one eye will be affected and then the other. But bacterial, they are almost always unilateral, unless a person, it rubs the eye, the discharge from one eye, it goes and infects the other eye. But usually all bacterial, they are unilateral conjunctivitis. So looking at if both eyes are affected, you can have a clue of the diagnosis. Then you need to know the medical history, the immune status of the person, atopy, Stevens-Johnson syndrome, there is always exposure to a particular drug, medications received. Very important to know what that patient has used in the past. If he has used long-standing, long duration of exposure to steroids, topical steroids, you have to look for the complications of steroids, most important, glaucoma. Then social history I've just mentioned. And once you have taken the history, you make an idea that am I looking for a viral problem, or is it allergic, or is it bacterial? And with that perspective in mind, when the patient is there on the slit lamp, then you look for those signs. And if the patient has already used the treatment like other anti-inflammatory agents like steroids, then you have to look for the complications caused by those eye drops as well. So with that information in mind, you start assessing the patients. So the signs, whenever you start your examination, it has to be systematic. So systematic examination, then you don't miss anything. If you make the patient sit on the slit lamp and immediately you start focusing the light on the cornea or the lens, you will miss the other information. So systematic examination when the patient starts when the patient walks into your clinic. You have to see how is he coming in. Are there any problems with that patient? When he's sitting talking to you, you should be carefully looking at the patient and listening to him carefully. For conjunctivitis, it's important to look for regional lymphadenopathy, particularly preauricular, because that is an important clue towards adenoviral infection and chlamydia infection, and for of course any malignancy. So bacterial and allergic, they don't cause preauricular lymph nodes. They can easily be felt in front of the tragus, and you put your both fingers and you can easily feel them. Then on the skin, you can see whether there is eczema, seborrhea or rosacea on the generalized, either in the face or on the hands, and that will give you a clue of atopic conjunctivitis. Then abnormality of eyelids and adnexa, regarding any swelling, discoloration around the lid margins, any nodules, acubosis or neoplasia. And then you start looking at the conjunctiva, where is the most congestion. In conjunctivitis, the congestion is inferiorly in the fornix, and then the congestion is maximum in the fornix and it reduces as you go towards the limbus. On the other hand, if it's a corneal problem, then the congestion is maximum around the limbus. It's called the ciliary congestion, and then it reduces as you go towards the fornix. So conjunctivitis, you have to lower the lid, you have to invert the upper lid, and you have to lower the lower lid and see for these follicles or papillae, and notice where they are. Papillae they are formed due to inflammation of the conjunctival structure, because conjunctiva is firmly adherent to the underlying tarsal plate, and when there is oozing of serum, these papillae, they form, they have a central blood vessel running in them, around where there are cells around them, and it is pink in color due to congested conjunctival epithelium which is swollen up. On the other hand, follicles, they are specific and they are pale in color, and they are due to the excitation of these lymphocytes, aggregation of lymphocytes, and they are a sign of viral infection, or they are a sign of drug irritation, chronic drug irritation. And these follicles, if they are present in the lower conjunctival fornix, they indicate that either it's a drug allergy, drug toxicity, But if they are especially present in the upper tarsal conjunctiva, you invert the lid and you look at the upper tarsal conjunctiva, they are pathognomonic of adenoviral infection or herpes. So it's important to look upper tarsal as well as the lower tarsal conjunctiva. Then you must look at the cornea in every disease. As I said, cornea will be affected secondarily, either because of the disease itself which is extending onto the cornea, because of the disease the tear film has been disturbed, or because of your treatment the tear film has been disturbed and the cornea loses the stability of the tear film and becomes dry like a rock, like this earth which doesn't receive any rain. And so if the cracks appear, the cornea becomes dry and lustreless, and if you put a drop of fluorescein in the eye, then that fluorescein, it breaks up and there are dark islands in between blinks, and this is detected as the reduced tear film breakup time. So just by putting a drop of fluorescein in the eye, you can diagnose whether the tear film is disturbed or not, whether the cornea is affected or not. And if the cornea is affected, then you see that staining pattern, the superficial punctate keratitis, and you have to note it down because you have to treat that cornea, that tear film instability along with your conjunctivitis. If you don't do that, that cornea will get worse and worse. Conjunctivitis will be better, but the state of the cornea will be disturbed. So when you're looking at the lid margin, you have to see whether the cause is an entropion with all the eyelashes bending inwards, pointing inwards, and then you have to evert that upper lid to see whether there is underlying trachoma, which is a very common cause of entropion of the upper lid, and there is scarring of the whole of the tarsal plate. So the eyelid and the eyelashes turn inwards. All these inverted eyelashes, they will cause abrasion of the cornea and will disturb the tear film further.